Okay, so firstly, thank you very much to Mark and the other organisers for inviting me to talk today. It's a great privilege, and also I'm very much looking forward to the rest of the conference, in the sense that I think that one of the key sort of unmet challenges is kind of modelling human behaviour, and I'll kind of try and touch on that in a minute. I do probably have to slightly disabuse Mark of his previous comment, because actually I'm going to focus more on methods, because I think a lot of our efforts in the Scottish COVID Response Consortium have focused more on sort of methodological gaps that we perceived, and so I'm not actually going to talk that much about specific results for Scotland. So yeah, the work that I'm going to talk about today is the result of the efforts of many people. I've listed the key people here, but I've probably missed some, and I apologize for that. But the further details on who has been involved can be found at the Scottish COVID Response Consortium webpage, where we list. Okay, so the Scottish COVID Response Consortium was formed in response to the ramp call, so at the beginning of April, I guess, last year, which, as Mike said earlier, is seems like an awfully long time ago now, from three organisations. So the Biomathematics at the University of Glasgow, the Scottish Government Centre of Expertise on Animal Disease Outbreaks, called EPIC, which provided a lot of the initial epidemiological expertise, and then several staff from Biomathematics and Statistics Scotland, where I'm based. And we submitted a proposal to RAMP, and as a result of that, we were able to meet and work with many volunteers on the RAMP initiative, particularly on the research software engineering side of things. So what I'm going to talk about today, this is an outline of my talk today. So I'm going to talk about something which came up as a sort of guiding principle of the work we were doing in the COVID Response Consortium, which are open epidemiology standards. And then I'll go and talk about some of the issues that come out of that, in particular, where we've tried to develop new methods and new approaches. So that's visualization, data pipeline, which I'll explain later, and new methods for inference for epidemic models to try and tie models better to the available data. And then I'll come back at the end, and I hope, in not too ham-fisted an attempt to try and link what we've been doing to the themes of this meeting, and suggest some areas where I think there might be overlaps between the sort of two communities, which I feel are relatively separate at the moment in terms of epidemiological modelling and kind of things that people in this meeting are perhaps more interested in. That may be wrong, of course. So in terms of open epidemiology standards, one of the first things that we identified, and I guess this came out from the media coverage early on in the pandemic, was that that understanding and communication of sort of model outputs was perhaps an area that needed some improvement. So what we're really trying to do is assess the readiness of our analyses to support policy, and that's quite a difficult thing to actually do in practice. And we feel that could be best supported by ensuring that data and models are traceable, and I'll come on and talk a bit more about that in a minute. There's a standard kind of peer review type approach, sort of assessing data and science quality, and then there's also an element which we, and again, and this was definitely seen with some of the early coverage of the imperial models that were used to sort of in the early phase of the outbreak, that ensuring that your models are open and open source and reproducible is really critical. And then underpinning that, also there's the idea that we need to parameterize these models in a way that reflects uncertainty and the data and information that's available at the time. So this is kind of boiled down into something along these lines for communication with policymakers. So something like an open epidemiology scorecard, where we would score each of our model assessments on the basis of how well they were to what extent they accorded with these sort of principles of open epidemiology. So and then today, as I mentioned earlier, I'm going to focus on sort of 3 key elements of this. So the first one, the ones that I'm not going to deal with are the sort of systematic peer review, and I do think that's an issue that we came up against in the pandemic. It's actually quite hard to find people who are going to do this, and maybe this is something we need to do better next time. Although I'm aware that the Royal Society did also make great strides in this process, in this aspect. Another area which I'm not going to talk much about, but was a key part of the Scottish COVID Response Consortium, was making everything that we did available in an open source way via GitHub. So we have a GitHub repository for all our work, and that was greatly benefited from the input of the research software engineers that came through the RAMP initiative. So what I am going to talk about is some issues to do with visualization, some work that was done by a group associated with the COVID Response Consortium. Then I'll talk a bit about the data pipeline, and then I'll focus mainly on these inference methods before coming back to talk about issues related to behavioral response. Okay, so this work has been led by Min Chen at Oxford, but also many other colleagues, many of whom are listed in this as authors on this paper that's in preparation. And so what this work really identified was that visualization is kind of something which is often seen as a kind of add-on, but is actually really critical to all stages of doing modeling and data processing and analysis for informing policy related to the pandemic. So a lot of this work can be seen at the RAMP Viz team's web page. So for example, they've developed various ways of visualizing death data in ways that, so some of these approaches are typically aimed at policymakers, and they're aimed to show information in a visually appealing way that gets across a lot of information in a small amount of space. So here I'm showing two examples of death data in Scotland broken down by gender. So here, and then also by location in terms of care homes, home and hospitals. And then perhaps more interestingly, from our point of view, there's an awful lot of work going on in terms of trying to make visualization tools useful to modelers. So for example, this is this work here is looking at visualization of a spatial model and trying to provide interactive tools. I can't show the interaction here, unfortunately, but interactive tools to allow the modelers to understand better how their models are behaving as a sort of diagnostic tool. And then another area that we're working on in terms of trying to provide information to policymakers is we're currently, and it's just about to be released, developing a dashboard to access all the data from Scotland at a fairly high resolution to allow local authorities to visualize this data and make decisions based on what they're seeing on a weekly basis. So, for example, this is an interactive map. It allows you to sort of zoom in on different areas. We provide, for each local authority area, we provide a sort of text summary on a weekly basis, and you can scroll back through the weeks. We also provide case rates in terms of test positive cases per 100,000. And so you can look at these different areas. And so, for example, as you track back through this, you can see areas which were taken out of lockdown, but where some areas within that local authority were had relatively high rates, and perhaps indicating that there was some risk in removing the lockdown. We also provide information on weekly ratios. So these are just a very simple case ratio of 1 week to the next, and this gives a rough indication of the reproduction rate of the epidemic, and it's been shown in other studies to be quite reliable in informing, compared to R0 estimates, relatively reliable. Okay, yeah, and then as I say, this has been released this week, so you can visit it and have a look there. And if people have comments, we're very open to trying to provide other information. Okay, so the other area that we have done a lot of work on is the FAIR data pipeline, and this links to the idea of traceability of models and trying to link models and model outputs to the underlying data that they are based on. So I'm not going to go into the details of this, partly because it's not my research area, and partly because it's quite complicated and also evolving at the moment. But the basic idea is to set up a software infrastructure that allows modelers to plug their model into available data, to register data that they have available but which they can't share with anyone else, into this framework. And then this allows tracing. So for example, if a data source becomes suspect at some point, or there's some issue identified with a data source, that can then be flagged, and then any model outputs that depend on that will then also receive show a flag to indicate that there is a potential problem with the analysis. And here I should say that we're interpreting data in a very broad sense, so data could also be models and model products as well. Yeah, so this is kind of what I just said. So this allows a kind of audit trail for each model, and so provides transparency and improves reproducibility of results, so that people can see exactly what's gone into a given analysis. So this is currently being developed, but we're aiming to make this available as a kind of general tool for the modeling community. And this idea then plugs into this idea of the open epidemiology standards, because it allows it kind of supports this idea of this scorecarding, and it means that the scorecard itself can be a kind of live document as the situation evolves. And as we saw several times during the pandemic, data sources suddenly changed in terms of what they were showing, or the denominator population was found to be poorly represented, and so on. Okay, so now I'm going to move on and talk about some slightly more technical results to do with inference for epidemic models. And so the motivation here is that really that if you're trying to do modeling to support policy, then you really need to ensure that your model is grounded in the current data, and also reflects the uncertainty that there is in the scientific understanding of the outbreak at any given point in time. So what are the kind of things we really want to do, and that we have been doing, are, for example, trying to estimate the reproduction rate over time of the outbreak. So this represents the early phase of the outbreak, and this dotted line represents the initial hard lockdown in March last year. And so, yeah, we might want to be able to estimate this and then project forward what's going to happen using models. And we want to do this using all the data that's available. We also probably need to account for prior information, for example, information on things like the generation time that we were hearing about earlier, possibly from other jurisdictions, like from Wuhan in this case, in the case of COVID. And then we also want to be able to propagate uncertainty forwards in time, so to represent how uncertain we are about the data. And then we also might want to do sort of counterfactual type things. So for example, think about if we'd had border controls earlier on, or more stricter controls on movements earlier on, how might that have changed the outbreak? And so what would the effect of possible measures that weren't taken might have been on the outbreak? So here I'm showing estimates of the impact of imported cases before lockdown. Okay, and the types of models that we might want to fit are somewhat should be somewhat flexible. So we want flexibility to fit various different types of models, because we might find that one model is more suitable than another, and that might change over time. For example, we might suddenly realize that we have new variants coming in and we need to model multiple strains and so on. So this is illustrative of the type of models that we have been fitting. So we have susceptible individuals. When they become exposed, they then have a kind of a choice, although it's not obviously a personal choice, but to move into either the asymptomatic branch, where they are asymptomatic but infectious until they recover, or the symptomatic branch, where they have some pre-symptomatic infectious period, and then they move into various infectious stages, which can result in either recovery or possibly hospitalization, or possibly to become critically ill at home, or unfortunately for some too many, as we've seen, to die. And then this type of model can then be extended in a number of ways. So for example, we might want to embed this kind of dynamic within a spatial meta population, sort of representing real areas. So for example, it could be health boards. We've worked with various levels, so health boards, local authorities, and this is the sort of lowest area we've actually done inference for, which is these intermediate zones in what are called intermediate zones in Scotland, and correspond to these MSOA level in England and Wales. And then we might also want to be able to estimate different effects, like effective age, gender, ethnicity is something we've not actually looked at because we haven't had the data, but that is potentially something that you might be interested in. And then you might also be interested in things related to the area, so things like density or deprivation. Okay, and then we've taken a rather sort of probably what I think this participants at this meeting might find is a rather crude approach to looking at mixing between areas. So we've just been using the census flow data on commuting from the 2011 census, but this could undoubtedly be improved. And so this allows us to generate a matrix of contact rates between different areas. But it's important to say that this just provides us framework on which we then do inference to try and estimate actual contact over time. And then another source of information for us, at least, has been, which again could be criticized for being somewhat out of date, is the age-related mixing from the PREM study. And so when we embed that into a kind of spatial model, we get a framework a bit like this. So we have an overall force of infection, which is going to depend on various terms. So we have potential individual effects, and then transmission between transmission rates, which can vary in time, and then can be affected by various regional effects, for example, and then depend on contacts between other areas and other age groups. And there can also be, as I mentioned earlier, a kind of external source of infection from outside, in our case, outside Scotland. However, most of the results I'm going to show today are going to be, or at least the latter set of results I'm going to show today, are based on non-spatial models. So the types of data that we are interested in showing are kind of interested in using are kind of illustrated in these plots here. So we have information on hospitalizations, which in the model that I showed is a particular transition within the model. So we know when individuals go into hospital, and that informs on that compartment. We also have information on deaths, but at various points before we got access to the sort of full Scottish data, we were relying on what was published, and that was deaths were only published as a sort of aggregate over the whole of Scotland rather than being broken down by different local authorities, which obviously hospitalizations are given by different hospitals. And then we also have case data, which is somewhat hard to handle because different numbers of people are being tested at different times, and we don't really know who is, the rationale for testing changes over time as well. So it's not just that the numbers change, but also the targeting of it changes. So the problem we want to solve is that we want to implement Bayesian inference, but the available methods that we have are either exact and slow or approximate and perhaps not accurate enough. So that's what I'm going to explore in this talk in the next section. So I apologies if this is overly technical, but I think it's important to get across some of the difficulties in doing this. So when we do Bayesian inference for epidemic models, what we are trying to do is estimate the parameters of the model, which tells us these transition rates between these different compartments and the contact rates between different areas and different individuals of different ages. And we're also trying to estimate we're kind of forced to estimate the different events in the process. So for example, we only see hospitalizations and deaths and possibly cases, but we also need to estimate when people became infected and when they transition between the different, when they transition from pre-symptomatic to asymptomatic to infectious and so on, infectious, symptomatic and so on. And we do that by combining a process model that I've shown you already, which is essentially tells me the probability of generating any given trajectory of the epidemic given my parameters. And we combine that with an observation model which relates that underlying model to the data that we've observed. So typically that might be something quite simple, like a Gaussian observation model, where I look at the number of hospitalizations, say, or deaths, and compare it to the model output in some way. And then also the Bayesian approach allows us to fold in information that we know beforehand, for example, about the length of the asymptomatic period, for example, that we might have good information on that. Okay, so when I talk about simulation, what I'm really talking about is drawing from a joint distribution where I draw parameters from my prior distribution and then I simulate the model using those parameters. And a useful quantity that I'll come back to later is the model evidence, which allows me to compare different models, and that is simply an average of the observation model over simulated parameters. So I simulate parameters according to this process and I can estimate the model evidence. Okay, but that is computationally very intensive to do. So there are different ways to, yeah, I should say when I do Bayesian inference, what I'm really doing is sampling from this posterior. So I'm sampling parameters and these event histories in a way that's consistent with the data. That's the take-home message here. And there's various ways to do that. So there are kind of exact approaches, and the sort of standard exact approach are called data augmentation, and that's essentially because I augment my data with pretend or simulated events, and I form a list of these events that happen, and then I perturb this list in a way that's consistent with the posterior and allows me to draw samples from that posterior. So the standard approach that to do this is to make changes to this underlying history, this state space, and to the model parameters independently. But what you typically find there is you get very poor mixing, and mixing here means that the sampling of the posterior is very slow to generate new, genuinely independent samples from the posterior. So the whole algorithm is slow. And one of the things that I'm going to focus on in this talk are something called model-based proposals, which kind of use the properties of the model to come up with a joint proposal of the parameters and the state space in a way that improves mixing radically in these data augmentation schemes. Another approach that people take, and we found was essential for estimating parameters for COVID, is to essentially cheat and try and solve a different problem to the one you really want to solve, which is where you take the observation model and you raise it to some power. And we can think of this as kind of heating the posterior in such a way that we flatten it and make it easier to explore. And so if we have high temperatures, then the data essentially provides no information about into the posterior, and so we're just simulating from the model. And if we have very low temperatures, then the data is constrained to be the model is constrained to fit the data exactly, which is probably unrealistic. And when we get rid of the temperature, we go back to what we call the cold chain, which is the posterior that we're actually interested in. So you can do this, and you can set off these kind of chains to explore different parameters. So here I'm looking at the probability of hospitalization, and as you cool the chain down, things get harder. But if you start with high temperatures and you go towards a cold chain, you eventually get to something where even before you get to the phi equals 1, the case we want to solve, what you find is that you get to a situation where changing it doesn't make that much difference. So what this is telling us is we can get away with some level of approximation, but not too much. Okay. Yeah, so when we're doing these algorithms, we kind of go through an annealing stage as we produce samples, we go through an annealing stage. Sorry, struggling to say that. And then once we've reached a temperature which we think is sufficiently accurate, we then do our sampling. And you can take this a step further, and actually, rather than do one chain and simulate and do this annealing, you can actually have multiple chains all at different temperatures. And then in various ways, you can swap between these chains to allow mixing to happen. So you get the benefits of this high temperature change, but you still also sample ultimately from the cold temperature chain. And this allows us to sample from the posterior and estimate this model evidence that I was talking about before. And this was actually quite successful. So we were able to come up with spatially varying estimates of R0 for the first lockdown. But what we found is that as time progressed and more, so this was based on individual level stochastic models. But as we found, as time went on, the number of infections grew, and therefore this method became computationally infeasible to sort of carry on with, unfortunately. So this led us to go back to think about more approximate methods. So the kind of standard approximate method is approximate Bayesian computation, ABC. And what we do here is we kind of we imagine this. We have some data on hospital emissions given by these blue dots, and then we can simulate a model, and we might get these crosses. So on a given day, like this point corresponds to this data point, and so we have apologies, I got that wrong. So the data are the crosses and the blue is the model, and so we kind of have a predicted value and an actual value, and then we can compare those in some error function and add up the differences, and we get an overall error function for the model run that we've just done. And we can do this repeatedly, sampling from the model, so drawing from our prior distribution and running our model, and we can look at the distribution of this error function. And what we find is that most of the times the model fits really poorly because we don't know what the parameters actually should be, and occasionally we get a good fit. And so ABC basically uses this approach, and it says that unless my model error is less than a certain amount, if my model error is above a certain amount, I'm just going to reject that version, that run and that set of parameters. But if it falls below a cutoff, then I will accept them. And you just keep doing that, and eventually that will give you a sample from the posterior and give you nice parameter estimates, but it is very computationally intensive. And typically what we find is that it's almost, you almost never get things that are below a sensible, reasonable cutoff. So to try and solve this, there's another approach called ABC SMC, or sequential Monte Carlo, which tries to solve this problem using particle filter methods. And essentially what that does is you run a cloud of particles, so you have lots and lots of computers running each of these simulations. And then, so your generation one particle is just one of these simulations that I mentioned at the beginning. So just draw from the posterior, run the model. And then these are perturbed and resampled in each generation, and you progressively increase the threshold as you go. Sorry, you progressively reduce the threshold as you go, so that eventually you get a reasonable sample from your posterior. And essentially this is borrowing ideas from sequential Monte Carlo and things like particle MCMC. And so we realized that there hadn't been an approach which tried to combine these ABC methods with data augmentation. So that's what we that's what we tried to do. And so we came up with this new algorithm, which essentially we start off with a cloud of simulation points of particles. So each one of these represents a simulation with a different set of parameter values, and we work out this error function that I mentioned before between the data and the model. And then we just cut off. So for example, we just divide this in half, and we take the best half. And so we get rid of the worst half, we keep the best half, and then the best half, we duplicate all those particles, so we still have the same number. And then we use these model-based proposals to perturb the state space trajectory. So in other words, the epidemic trajectory for each of these particles, and that essentially allows us to separate those points that would otherwise be the same. And we just keep repeating this process, so then we have a new cutoff, which is slightly lower, and then we keep going. And so as time goes on, we get better samples that are close, have a lower cutoff. Sorry, I'm pointing at my screen, which you can't see. Have a lower cutoff and a better error function, and eventually we get to a set of samples which are actually reasonable samples that were from our posterior that we're interested in. And we can do all that. We can essentially do all the things we'd like to do. So I'm going to skip that for time reasons. So essentially the point is that this approach is very similar to standard ABC, but by using these model-based proposals, we preserve some of the information that we've learned about the trajectory of the epidemic in each stage. Okay, so the question is this any good and is it any useful? So what we would like to do, as I mentioned before, is to try and estimate the time varying trajectory of the reproduction number. So this is a simulated scenario because I want to know whether I've got it right. We're just going to fit this model again, and then we're just going to use data on hospitalizations and community deaths. Okay, so if we do that with a large cutoff, what we find is that we get we can do the estimate, but we get very wide confidence intervals, and it's essentially kind of useless. And if we improve the cutoff, then that our estimates gets better and more useful. And so we can characterize our different inferences in terms of these cutoffs and how low we can go with these cutoffs. And then we can look at different algorithms and ask whether they allow us to get to a decent cutoff. So do they get us into this, somewhere between this reasonable and good regime? And what we find is that the kind of existing methods typically do rather badly. So this green method is standard ABC, and this blue one is SMC ABC, and it requires an awful lot of computation for it to get into this good region, whereas we get there much quicker. And I'm just going to skip through that. There's various variants of these algorithms, and essentially we find that some are good and some are fairly bad. Interestingly, one of the ones we find is quite bad is this particle MCMC, and that's the one that was used by the Imperial team to fit their model. And so although they obviously did get some fits to that, we think that this is a much more promising approach. Yes, so another message from this type of approach is that some parameters using the data that's available, some parameters can actually be estimated in the model, and other parameters can't be very well estimated. And so these are the ones that we would typically think of as needing some better prior information from previous studies or sort of more directed studies of hospitalized patients and so on. Unfortunately, these are things that can be estimated, so things like the latent period and the symptomatic period and so on. However, one way of using these tools is to think about what kind of data that we should be collecting. And so this is this feeds into this idea that possibly we could collect better data during a pandemic to help inform models, and we can use these type of inference approaches to estimate how much information a given set of data might provide. And so that could be a useful thing going forwards. Okay, and just in the last few minutes, so I think I'm coming up to 40 minutes, I just wanted to say a few words about modeling behavior. So, so the work that I presented here is a kind of, in a way, a standard way of thinking about epidemic modeling. So the behavior that we're got in the model is essentially captured by the contact rates, which lead to transmission between individuals, and these could vary by population and age and so on. And these inference methods allow us to estimate these contact rates. And so, for example, as I've shown, that we can estimate the we can actually come up with fairly reliable estimates of the impact of different interventions. And we're currently working on trying to tie in, for example, the different levels, the different tier levels that were used in Scotland in various places. We're trying to tie that in with these estimates and see whether we can actually understand in a more comprehensive way the impact of lockdown on contact behavior. However, obviously all those estimates are confounded by whatever else is going on. And my feeling is that these kind of estimates, although they're useful in terms of quantifying what's happened, they're not going to be very predictive. And so we would like to be able to incorporate behavioral representations of behavior into epidemic models in a way that's not too computationally intensive, that would allow us to do these kind of inferences. And my feeling is, and my hope is, that I'm going to learn a lot this week, the next couple of days, about how this community is doing this. And I think that the data that we have available now is obviously very useful in that. However, I just wanted to end by saying that I think there's some lessons that could be learned from some of our work on livestock diseases, because there's an analogous scenario that happens. So in livestock disease, we have very detailed information in lots of countries, and in particular in the UK, from the cattle trading scheme, which told us the movement of animals between farms. So in that context, that's the kind of behavior that farmers indulge in because they need to, stock their farms. But it also spreads disease. And so the typical approach that people take is to simulate epidemics on a sort of replay of past movements, and that's kind of useful. But what we'd really like is a sort of mechanistic model that allows us to, well, fitted to this movement data, but allows to represent a realistic and generate novel but realistic patterns of movement. And so that would enable you then to test different interventions, which is kind of exactly the kind of thing that we want to do with COVID. So we've kind of recently been developing this kind of simple approach to this, and I kind of wanted to show this because I wondered whether it chimes with any of the things that are being done. So in this case, we characterize each farm by a kind of supply and demand rate, which characterizes the average number of animals that a farm will buy and sell in a year. And of course, farms can generate animals through breeding and so on, so these don't have to match. And then we kind of model the partnerships. So we model the buying behavior of a farm in these terms. So we say that each farm has a list of trading partners that it trades with, and this can be added to, and farms can be added or removed from this list, but this is the basis of who it trades with. And so this then allows farms to identify animals in a selling farm that they can then buy. So for example, here I'm showing farm JK has now sold an animal to farm I, and it's arrived on farm I, okay? And you can parameterize all this kind of dynamics using the data that's available. Oops, sorry, I'm going the wrong way. Okay, and then you can imagine that if farm K was diseased and sent a diseased animal to farm I, then farm I could transition from being a susceptible farm to being an infectious farm. Okay, so I can think about the spread of epidemics on this trading network. Okay, and then just the sort of the very quick message here is that this really simple model, and it's kind of surprisingly, we were surprised how good a fit we got to the data that we had available. Obviously, I'm not able to go into details about this, but I can talk about it more later. So we're able to fit this at quite large scale. So we have something like 13,000 farms in Scotland, and we get a reasonably good fit to the data. And then this allows us to do some interesting things, and there's some interesting behaviors that come out of this. So one of them is that sorry, I've got an alarm going off there. One of them is that sorry. So we get some interesting behaviors from this in that we get some non-intuitive outcomes. So things that people have previously predicted would reduce disease, we find they don't, because we get these compensatory behaviors where farms kind of trade in different ways to get around some of these restrictions. Okay, and so yeah, that's essentially the end of my talk.
Okay, thanks very much, Glenn. And yeah, very interesting. And I'm sure that as you say, well, I hope that you will learn much from the talks to come, and I'm confident that the speakers to come have found much to engage with in that presentation. So thank you very much. I'm keen to keep us to our quite ambitious timescales, but perhaps I could have Chairman's privilege and just ask you one question before we move on. Yeah, I'm very interested in your comments towards the end of the presentation. Again, I think you use slightly different language to what I'm used to, but yeah, essentially, yeah, issues relating to the importance and kind of the gaps in the data, as opposed to issues regarding the quality of the models and those kind of questions, especially when you're relating that to the kind of the predictive capability of the models. Could you give me I mean, I know what I think, but I'd just be interested in your broad brush view on where's the balance of need here, between requiring better data to feed into the models and actually requiring better methods and approach in order to do something with it. So especially if we're thinking about being able to make perhaps especially policy-based predictions.
Yeah, I mean,
intervention.
So obviously I'm interested in methods and trying to squeeze as much out of the data that's available as possible. So I obviously think that there's still a lot of room to do that. But I think there's an awful lot more improvement that could come from better data and better access to data and sort of better linking of data.
Okay, that's great, thank you. Can I encourage everybody, we do have a session for questionnaire at the end of the morning, questions and answers, as well as another one later in the day. If you have further thoughts, questions, then please do post them into the Q&A and we can come back. I'm not sure, Glenn, if you're with us for the rest of the morning, rest of the day, but if not, yes. I'm sure others will be also delighted to comment on those issues. But you are?
Yes, I am, yeah.
Great. So yeah, let's do that. So thank you very much.